This segment is basically called Hot Topics, and the three topics that we're going to be covering are precision medicine, minimal residual disease, and maintenance therapy. And what we're going to do is basically have each faculty member go through briefly an introduction to the topic, and then we're going to have an open panel discussion about the topic. And Dr. Gabriel is going to start us off with precision medicine.
All right. Thank you so much, Ajay. So good afternoon, everyone. Hopefully you enjoyed lunch and all the topics that we discussed early in the morning. Now, these are the areas where we as physicians were not even sure yet how to deal with those topics and how to move the research forward. But these are the exciting areas where hopefully next year and the year after, you will see that those become standard of care. You will see that that becomes incorporated in how we manage our patients. So it's very exciting for us. So the topic that I'm going to take you through is really precision medicine. And it's a very simple thing. If we take two patients and we look at their multiple myeloma, they may be completely different. Yet you heard us say again and again, high risk, low risk, and then we end up saying, oh, and we treat you the same way, 3-drug combination or 4-drug combination. You haven't heard us in the morning at all talk about if you are high risk, then I will treat you with something different, or I will add something else, or I will be looking at the P53 mutation, and then I say, yes, I should treat you with something based on this mutation or based on this chromosomal abnormality. So we recognize that that's a huge problem in our treatment management. We think it's okay for now because the drugs that we have are great to kill all plasma cells. That's wonderful. But we want to get even better than this. We want to say, yes, we can kill plasma cells, but we can do even more than that, killing specifically the bad ones that have certain mutations and prevent disease relapse, prevent those cancer cells from coming back. So the first thing you want to know is how do we change the treatment? And before we do that, you want to understand what's happening with the cancer cells. So remember that the cancer cells will acquire a change that makes them cancer cells, and they can divide on their own constantly without any checks and balances, without the immune system controlling them, and without your own body telling them stop dividing. How does that happen? We're not sure how you develop myeloma, but we know that as the cells are dividing, they have a small chance of acquiring a mutation or an abnormality, meaning as your DNA is dividing, one of them can get an error because we're doing all of those divisions all the time, and there is an error that happens every millions and millions of cells. And sometimes those errors will happen by acquiring something called translocation or copy number alterations. So what does that mean? Your DNA is wind down into the chromosomes. So as you can see here, the chromosomes are very important, and we have a lot of those chromosomes that should be normal. Yet in many of us, we could even have either an extra copy of one of the chromosomes, or a deletion, a small piece of the chromosome will be removed, or pieces of chromosomes will be taken from one and given to another one. And this is called translocation. So for example, a 414 translocation, I'll take a piece of the chromosome 4, a piece of chromosome 14, and exchange them with each other. Now, why would that be important? It means that those genes that come together now, when I exchange in the chromosomes, they will tell each other, why don't you now enhance transcription and allow the cells to grow faster and faster, and tell the cells, you don't need to worry about the immune systems. You can overcome the immune system and keep growing. So this is what we call oncogenes or tumor suppressor genes, which are the other ones, and so on. Now, how do we test all of this? There are so many different ways that we test it, but I'll show you an example. Here's two patients in the COMPASS study, and you've heard us already nicely talk about how COMPASS was so important for us because it gives us the next level of understanding of your genomics, of your own genes. So these are two patients, almost the same age. Both of them are women. Both of them are the same international staging system, which is the albumin and the beta-2 microglobulin. Both of them got the same treatment, Revlimid, Velcade, and dexamethasone, and both of them, by the typical clinical settings that we use, the cytogenetics and FISH, had exactly the same things, a 414 translocation, a deletion 13q, a 17p deletion. Yet one of them had an amazing response and lived for a long time, and the other one, within 1 month, progressed. So why would you have some differences between them? And the answer came very nicely, that you have an acquired extra mutation in the P53 in one patient and a wild type in another patient. And this is important to understand because this is done by something called next generation sequencing. So the FISH and cytogenetics that we do clinically for everyone look at big pieces of chromosomes being changed or removed or added. We don't look at the single cell or at the single DNA level. However, with next-generation sequencing, which is a huge revolution that just happened within the last few years, we now can look at every single mutation and every single DNA piece and tell you if this has changed or not. So that level of next-generation sequencing can help us understand so many things that we didn't have before. And this is being done routinely now in the COMPASS study. It's being done in many academic centers. And it will actually become, hopefully, a standard of care as we develop something called targeted panels so that we can understand mutations. And by having a P53 mutation along with a 17p deletion in another arm, something called biallelic P53 deletion, that leads to bad prognosis. So that can explain potentially why this patient did so badly in the treatment while the other patient did much better. Now, how can we change things? Again, you've already heard about COMPASS, which was the biggest study that we had of really putting all the data, sequencing all the samples, next-generation sequencing, but not only that, delivering all the data to all of us so that we can look at it. And that was the beauty of it, open access, so that every single physician or researcher can look at the data of the 1,000 patients and start asking questions. Many of you work in the fields with Google and Amazon and all of that, and the idea that collectively, people can get smarter by asking different questions is exactly what MMRF is doing right now. They're asking us all to look at those 1,000 cases, at all the next-generation sequencing, and starting to ask different questions so that we can get smarter and potentially come up with better drugs and better options for our patients. Now, you'll say, well, so what that you sequenced my sample and so what that you got a P53 mutation and a KRAS mutation? Who cares? There are no drugs for it. And the answer is, let's stop here for a second and see. Maybe there are no drugs right now for KRAS mutation. However, if you have a KRAS mutation and you're activating a specific pathway, which is like the small little proteins that talk to the genes and get to understand it, then we can develop specific drugs for that area called the MAP kinase pathway. So there could be ways where we can actually target the gene change, the mutation, but maybe not directly. And this is important for the drugs that we have right now, but it's also important to understand that if 20% of you have KRAS mutation and there are pharmaceutical companies there trying to figure it out, they will know that if they develop a KRAS drug, immediately we're ready for them. Immediately we say, we have the biology, we have the mutations, we need that drug to come along. So even understanding the biology without having the therapy ready yet is also very important. Even if I don't have a drug right now, knowing what your disease has is knowledge, and knowledge is power. And I think that's very important for all of us to know. So how can we target this? Some of those drugs, for example, or some of those mutations, something called MYD88, very rare to happen in myeloma, very common to happen in Waldenstrom, and there are drugs specifically for this one, or drugs that affect the pathway, the proteins that change it in that area. Cyclin D1, which is CCND1, and you don't have to remember all of those. Again, we have drugs that work on this called cell cycle inhibitors. BRAF is the best example for that. So it happens in only 8% of our patients with myeloma. It's the most common mutation that happens in melanoma. BRAF mutation is actually the most common one in melanoma. And we have BRAF drugs. We have that already. So we are already testing using BRAF drug in combination with our standard of care for patients who have BRAF drug. And the last example that I'll tell you, which you've heard it already for venetoclax, patients with an 11-14 translocation. So it's not on this slide because this is just the mutations, but the big one, the translocation of 11-14, which is very common, about 15% of our patients have it. We are now seeing that those patients will specifically have a great response to the drug venetoclax. So that's already the first case of precision medicine in our patients with multiple myeloma. So again, this is just showing you the first case of BRAF, which I talked about. The drug that works for melanoma also works for multiple myeloma. If you have a BRAF mutation and you look at it and then you use drugs that work for it, which is here one case report where you can see beautifully a nice response to the BRAF drug. We don't think that this would work alone because myeloma has multiple mutations and alterations at the same time. In fact, by the time you're diagnosed with myeloma, you have something called 5 different subclones. So your cancer cells are not all uniform and do not all have the same mutations and the same translocations. In fact, when we look at your cells, it's as if you have 5 different types of cancers within one myeloma. So the multiple myeloma is not just about multiple omas, but it's also within that type of tumor. We have 5 different clones, 5 different types of cells within your own type of disease, which makes us understand why now we need multiple drugs to target it, but also why sometimes you have resistance, because you can kill 90% of the cells, but there is one subclone that has a bad mutation that wasn't present in all the other cells. The other cells were all sensitive and nice. This one small clone that had a P53 mutation or had a bad mutation will be the one that grows and causes resistance. So not only is it important for you to get your bone marrow biopsy at the time of diagnosis, but also when you get relapse and relapse and relapse, because the new changes indicate that you have a new type of clone, a new type of mutation, and it's important for us to understand that. Even if we don't have treatment yet, it's important to get to understand the biology so that we can develop better therapy for it. So let's think about ideas of how to treat patients with high-risk myeloma. So we all told you that we have so many things for high-risk myeloma. And one of the ideas is we do something called the bucket trials, where we take all patients with high-risk myeloma and we start understanding the different mutations that they have. And based on the mutations or copy number alterations, you go for precision medicine. You go for a specific drug. So this is an example of that, where if you have a KRAS or NRAS mutation, then you go for that MAP kinase drug. And again, I'm not going to give you all the details, but basically we give some specific drugs for specific mutations. And that's the first step for us to start developing precision medicine for myeloma. I'm hoping 10 years from now we'll look at this and say, oh yes, we knew that we should do that. Why aren't we doing it? But we're still baby steps here in understanding better mutations and how to target them specifically for our patients. The other thing of precision medicine is looking at some of those clinical trials that we have is something called FGFR3 and how to have specific drugs for it. So again, for those of you who have 414, 1416 mutations, many of our patients will have specific genes that are enhanced or increased, and some of those would be MMSET or FGFR3, and we indeed have some of those drugs specifically for those patients. And you can see here the list. This is not a complete list, and hopefully in the future there will be more and more of those clinical trials for our patients. So I'll stop here and we'll go for the next step.
So thanks to Dr. Gobriel. So a couple of questions that have come up about genomic testing for the panel. So how often, when should you do this, on which marrow sampling, and how often do you repeat it?
So I think there's a very good rationale outside of the context of a clinical trial to do this in relapse, particularly if there's patients have had many prior treatments and you're looking for options. I encourage participation in clinical trials where this type of testing is done to try to identify markers for specific drugs or specific types of treatment. My personal opinion is that the utility of this type of evaluation in newly diagnosed patients is somewhat less obvious because most patients will do very well with our standard therapy. So we're not, outside of the context of a clinical trial, we're unlikely to alter our therapy choices based on the initial bone marrow biopsy genomics results.
Yeah, I couldn't agree more. And I showed you on one of my slides that the patients who what we call penta-refractory, so they've had all the big drugs and no longer responding to the big drugs, or maybe looking for something else that is approved, FDA approved, we can buy it and use it and maybe have some effect. Now, I don't know that we do them multiple times. We do it perhaps once. Right now, the MMRF they have a clinical trial that you can participate in just by signing a consent and giving up some of your bone marrow cells. They'll send it to University of Michigan, and we get 1,500 gene panel sequence. That's what we do at UCSF, and it's free. And otherwise, the test would be thousands of dollars. So that's an easy clinical trial. That's easy frequent flyer points right there. The one thing that Irene did not have a chance to mention, which has been done at several places, but probably Arkansas the best, is they've done biopsies from maybe a plasmacytoma here, or a bone marrow biopsy on the left side, and a bone marrow biopsy on the right side. And they've gotten different genetic results. So it is a little bit dependent on what place you're sampling on to try to, if you're going to try to find a drug, you hope it's everywhere, that abnormality is everywhere, but it may not be. And I think Dr. Cho might have said something about looking at circulating DNA, like the liquid biopsy. Because if it's a liquid biopsy, you can get it in the blood maybe. It doesn't matter where the spot is. Hopefully we will evolve over the next 3 to 4 years to be able to do liquid biopsies so we don't have to do the bone marrow and still get a good potential for a drug just from a blood test.
So I guess to clarify, the COMPASS study was the initial newly diagnosed study. You heard Dr. Martin mention about the relapse sequencing study from Michigan, which I believe is closed to accrual currently.
No, it's open.
We were told it was, okay, it's back open.
So it's open at UCSF, so all you guys have to come to San Francisco, okay? But don't worry, come on out. We have good Pinot.
Okay. So newly diagnosed relapse sequencing. Somebody asked, is there going to be another COMPASS? And there are talks in the works about a son of COMPASS, COMPASS 2.0, if you will, which will be, which is in the planning stage. But in the absence of that, how would you, if a patient here wanted to get their sequencing done, where would you send it to outside of a clinical trial?
There's a couple of commercial options. They're not identical. They're sort of somewhat complementary. So one is what's called Foundation 1 sequencing. So this sequences the DNA from the tumor specimen. There is an option now, I think, available where they're going to separate out the tumor cells from the normal cells. But the original test, the one that's most widely available now, is just on the whole aspirate. And they don't sequence the entire genome. They sequence a targeted set of genes, but they're all genes that are relevant to cancer. The second test is gene expression profiling. There's a couple of different flavors, and one is in transition because the company that does the test was purchased by another larger company. But that's looking at the expression levels of certain genes. So you can see those are complementary tests. One is looking for mutations in the genes. The other test looks at expression levels of the genes. And so if we don't have a clinical trial like the Michigan UMich profiling trial available, we would typically send these 2 commercial tests.
And in terms of the future with using these for therapeutics, do you see, you mentioned the heterogeneity from, say, a marrow versus a plasmacytoma. Given that heterogeneity, do you foresee, how do you foresee these targeted therapies being used? Single agent versus combination? Yeah,
so you made a nice introduction for that for me. That's an easy, I'll take that one and run with it. So one drug probably isn't going to work. So if we do 2 spots and find 2 mutations, it might be 2 drugs, but still it's only going to work in a subset of patients. I told you there's different clones. Some clones will have that mutation and some won't. So you can't just focus on just that mutation in a tumor bed. You have to go at everything. So you would do that drug in combination essentially with something else. And hopefully we'll have, like what Dr. Gabriel was saying, a better way to define what that something else is in the future as we interrogate all the genes that are present or overexpressed, et cetera.
And one last question about genomics and genetic testing. So patients who routinely get an initial marrow and get the cytogenetics in fish and so forth, how often should the repeat marrows be done? Not for these next-gen sequencing relapse, but just for how often should fish testing be repeated? After each relapse, once in a while? When should that be done?
I think as a rule of thumb, whenever you're considering a substantial change in therapy, it's a good idea to know what's going on in the marrow. And that's positive and negative. So if you have a patient who appears to be in remission and you want to confirm stringent complete remission, obviously you need a bone marrow biopsy. And whether that prompts you to stop maintenance or what have you. But anytime you're thinking about changing therapy, it's important to know if there's any substantial change in the genetics of the tumor. So, for example, if a patient does not have a P53 mutation at diagnosis, but when you're going into your second or third line of treatment, you do detect a P53 mutation or something like that, that may affect your choice of therapies or your intensity of therapies, duration. So things that might affect your decision when you're making a change in treatment or you're considering a change in treatment. I think my personal opinion is a bone marrow biopsy is always a very important piece of objective information to get.
Maybe a question Erica will ask too. Why do all the marrows, why do all clinical trials have baseline marrows, and is that really needed?
Okay, it's really important to have the baseline marrows because we want to see if there's been a change that we can relate to the study drug. We want to see if the response that you're having from the clinical trial drug is actually a response, and you need to have something to compare it to.
Great. Yep.